Hello, everyone, and welcome to another edition of the Cameroon Town Hall for Healthcare Professionals. I hope you're well. I hope your families are well. We're excited because we are fast approaching the 60th edition of the Cameroon Town Hall. Today is actually the 59th edition. And as we are drawing closer and closer to the end of the year, I know many of us here are having great plans for the holidays and are looking forward to great things for the holiday seasons. But it's also a reminder that, it's time for us to start thinking about how our 2022 has been going on so far. I've personally been reflecting and I'm, looking at what I could tighten before the year runs out. And I hope you have too. Back to our town hall, it's always a pleasure to have you all. And today's session we envisage is going to be a unique one. Why do we think it's going to be a unique one? Because we're going to be talking about radiations. It's not something that clinicians or nurses or pharmacists or nurses like we typically think about, but we have a group of specialists who at the back are weary of some of the practices that we've normalized. And we have an expert in these fields who is going to be enlightening us on what we should be doing, what's best practices, and what we need to be correcting. I am going to be co-moderating the session today with Elvis Dancy. Hi, Elvis.
Hi, Alison. Hi, our town hall fervent participants who always dial in every fortnight. It's always a pleasure to be here. Each time it's time for town hall, it's just like we have to let go every other thing and be here. So I'm really glad to be here, and I'm looking forward to a very exciting session, as you've mentioned.
Thank you, Elvis. And I will also be joined by Brian Tigomo. Hi, Brian.
Hi, Alison. It's good to see you. You look very bright today.
Oh, thank you.
yeah. I'm also really excited about today's session. I think it's a very important public health topic. I think all over Africa, not only in Cameroon, there's a lot of acquisition of medical imaging technology and so I think it's really important to have a conversation around how do we protect ourselves from radiation. So I'm really excited about this meeting today and starting this conversation.
Thank you so much, Brian. We're going to hand over the floor to our chairman to welcome everyone to the town hall and give us some COVID updates. Hi, Dr. Muno.
Oh, thank you very much, Alison, and thank you, Elvis and Brian. It's always wonderful having you here. I also want to thank our presenter for today, Dr. Joshua Tambe, who is my classmate. And as I would say, I know you guys are going to introduce him. He's a very, very brilliant person. It's an honor to have him in the town hall. I'm truly honored. And presently, the university students, the medical students in Boyer and those in the lab sciences and nursing department, they are blessed to have such a wonderful teacher. So without wasting any time, I'm going to go over to the updates and try to do them as quickly as possible. So concerning the town hall, as I said, today we're going to be talking about a unique subject. And I would just like to give some little updates. You see, we're still in the midst of the pandemic. We're chasing several viruses. We're trying to find our way out, and I think it's going to be difficult for us too. Now, this is really what happened. This is the peak of it. I know everybody's going to say, Muna, why do you put this slide on? Is the pandemic over or not? I personally don't think the pandemic is over, but it's important that we actually work our way forward. So right now, this is showing you the actual number of deaths that are due to COVID that was calculated. It shows that more people died than the 6 million that we're having. Almost about 25 million people must have died of COVID. And here, this shows you the impact on the life expectancy in the world. Here, the good news is that the number of deaths we're having from COVID is drastically reducing. This is in the US and most other countries, attributed to herd immunity and also to better management of COVID patients. Now there is, do boosters work? I just put this here because it does work and we should know about it and people should get boosted. There is now the bivalent booster, which is available in the US. There is still a problem in third world countries where we're unable to get this, or developing countries. Now, going back to monkeypox, I think we've done a lot about monkeypox. We do know that there are two clades, and the Central African one is the most, it kills more, but the West African clade is actually what is circulating right now. Modes of transmission, we know about this already. Good news is that the number of cases are actually dropping, and I hope we don't drop the ball, and WHO also, on actually doing research on zoonotic diseases and catching them early, and also prioritizing research in Africa and other places such as third world countries. Here you can see the number of cases as of yesterday. There were 65,415 cases. Majority of those cases were in the US, followed by Europe, in Spain, in Germany, in the UK, in France, and also South America is also having a lot of cases. While for the states in the US, if you're traveling over here, no, California, New York, Florida, and Texas, then Georgia, also shows you the amount of the kind of populations there. So for the lesions, I just think we need to be able to identify these lesions. These are the classic lesions, those who are back home in Africa, if you get a case like this, so that we don't miss it. But right now in 2022, we're having lesions. It looks more like sexually transmitted disease. And we're having lesions in the penile area, in the vulva, in the anal region, just in the oral mucal area, also showing the mode of practice, sexual practices. We do know that we do have some vaccines which are based on the Vaccinia Ankara, which have been proposed and patient, and we're actually giving them out to a lot of big people in order to prevent them from getting infected. There are two subtypes of vaccines that are being given, and we do know that they're given, one of them, the genus is given actually in a space, in the span of about 28 days. Now there's some treatment out there. There is no real treatment, which we say we're still trying to figure out, but topiramab is actually one of the treatments that is being used. And there are other options that are available, but you need to talk to your infectious disease doctor. Going back to COVID, we do know that COVID is actually a moving disease, and variants, so many variants. There are a lot of people engaged. Right now, this is the first time in science where we are tracking variants and actually trying to see how the disease progresses with different variants. We already have some of those variants. As soon as they pop out, there are researchers out there, people like Brian, they are able to know that these variants are existing, and we're trying to see which is going to overpower the others. So we're able to know that. There is also a lot of research going on in nasal vaccines at the moment, and some countries like India and China, they have actually approved some of them. We still are in the midst of getting new variants, so we need to know that there is still evolution of the virus going on. And here is just showing you the advantages of getting a bivalent COVID vaccine. Here is also data showing you exactly that is more efficacious. This is cumulative data that was published in New England Journal of Medicine showing the advantage of actually giving people boosters at this moment. You see that by giving boosters, you're going to actually cause a lot of herd immunity and prevent death. So these are actually the number of deaths that have been averted by simply vaccinating people. Long COVID is a whole big story. This is a New England, this is what was published in JAMA, trying to understand long COVID. For those who are interested, you can look through the slides, or you can actually read this paper. As I've said before, the COVID vaccine has led to many other important things. We're having a lot of vaccines in the pipeline for many diseases that we have not had vaccines before, including things like Ebola that you find a lot in Africa. There was an outbreak recently. You have rabies, you have Zika, you have HIV, you have influenza. All this research is still going on. So it's important that we know. And really, the next virus is actually going to be more potent. In order for it to replace the BA.5, it needs to be more potent. And there are several variants circulating, or subvariants that are actually that way. Is this the end? I don't think so. There are several factors. We've spoken about this several times. The lack of global commitment, lack of reduction of risk, co-infections, and also animal reservoirs is actually a big thing in COVID. So this is still the best way in order to survey, by doing sewage. Do not forget to wear your mask. The number of cases are increasing in different parts, in different areas at different times. And here we can see that by getting vaccinated, we can actually reduce mortality in all age groups. So you can actually look at this. This keeps changing depending on the risk. Now, if you look at the US as of today, this is the circulating variants. The BA.5 is gradually being replaced already by the BA.4.6. And there are several other variants that are existing here. So you should know that the things are changing gradually. This was almost a month ago. You could see the variants that were there. BA5 took over everything. And here you can see the difference between those variants. And here we just have a group of what the genomic tree looks like. So in addition to that, this is just important for me to show you this. There is the BA.2 variant and the BA5, just showing you the difference. And there you do have subvariants like the BQ1.1, which is one of the variants we need to look out for, the BA2.75 and the BA2.752. So for those who are interested in this kind of nomenclature, know that those are the things that are coming up. So we cannot shut ourselves out of the pandemic. Getting to the finish line, we need to learn to live with this. And we need a Swiss cheese model all the time in order to take care of this pandemic. The end of the road for Mars is not the end of the road of the pandemic. These are the number of people who have actually gotten sick. If someone had told me we're going to have almost 500 million people getting COVID, I would not have accepted. But we have given almost 12 billion shots of COVID, almost 13 billion as of today. So this shows you the number of people, the number of deaths. As I said, 6.5 million is the official number, but we have more than 25 million deaths that have been, people that have been reported dead or unreported in many other countries. The numbers in Cameroon have not changed as of last 2 weeks. So I think there are some cases, but they are not being reported. Here is the US. Here is old data also from Cameroon. We're still not vaccinating ourselves, and we're still not up to par with vaccination. So low-income countries are still being affected. There is still a lot of research going on in the pan vaccine. And I think we're waiting on the data from water rates in order to move forward with this. So vaccines do work. We do have data for this. And I don't want to lay emphasis on this. Now, when are we going to have the next variant? We're not praying for this, but it's going to come one day. And we hope we're going to be ready, and the world is not going to shut up itself. And the first country that identifies this is not going to be stigmatized like South Africa. So this is actually data for a dream vaccine. I hope we get to this point one day. In terms of therapy, not much has changed for the past 2 weeks. So therapy still stays the same drugs that work do work. We do have interleukin-6 receptor tocilizumab, we have remdesivir, we have molnupiravir, we do have Paxlovid, and we have different monoclonal antibodies depending. In Cameroon and in Africa, we do have baricitinib can be gotten. We can get baricitinib. We can also get dexamethasone. And I think other medications are being made available. So these are the different indications in different circumstances. We can always talk about this later on. And this shows you the dosage. I have the dosage in my slides. Those who want my slides, I can always share them with you. You can actually see the dosage and actually learn how to prescribe them if you're in the position of prescribing them. So without wasting much time, I think these are the major updates. There are a lot of other things in my slides that you guys can look at. There is data coming out every day showing that things that we thought work do not really work. There is still data showing, more data coming that hydroxychloroquine doesn't work, more data coming out that antiretrovirals other than the ones we spoke about do not really work. So let's continue to fight the pandemic, and let's learn from this pandemic. I think this is one of the things that if we don't learn, if every country that has a CDC, Center for Disease Control, doesn't learn from this, then the world is just going to keep repeating the same mistakes over and over. So thank you very much, and over.
Yeah, thanks a lot. Thanks a lot, Osmano. And I think that was a really excellent updates. And thanks a lot for bringing these updates every day. You started the presentation with a really great slide on the President of the United States made a statement last week that the pandemic was over. So I heard that you disagree with that a lot, but I wanted to hear from your perspective, what criteria, what's that threshold we need to meet in order to say that the pandemic is over? I wanted to hear that from your perspective. What would be that criteria? What would be that threshold that you will feel comfortable in saying that the pandemic is over? Or are we going to be in this essentially for forever? And I also just wanted you to make some comments also about long COVID, and particularly what you're seeing in your practice as a hematologist. I think it's a very, very serious dual pandemic that doesn't get enough attention, and it's a lot of people who are suffering from persistent symptoms from COVID. And I think that that's something that's not getting sufficient attention. If you could talk about those.
Yeah, thank you, Brian. Those are very difficult questions, even for any public health person. I think we need to take into consideration the number of cases that we're having. Are we dealing now? You know, you can say the pandemic is over, but we're dealing with an endemic situation where we're going to deal with this forever. So it's transitioning. We're having a transition where COVID is having an epidemiological transition from being a pandemic, as we're calling it, and is going to finally end up being an endemic disease in several parts of the world, where we're going to have cases that will be coming up from time to time, and we don't need to give message that is going to make public health departments actually lose interest and lose research into this disease. That's really where my problem is coming. My problem was more about the messaging. I think we're transitioning slowly, but COVID is going nowhere. That's the truth about it. COVID is here to stay with us. It's one of those diseases that I think it's in the long run is going to be like the flu. We're going to need vaccines every single year. And I'm happy to know that the CDC and the NIH and everyone recommended that we're going to be having vaccinations actually queue yearly, and there will be dual they'll be mostly depending on the strain that is circulating. Now, going to the point of long COVID, in my practice, I really practice more like more in oncology than internal medicine. So I tend not to see a lot of patients who are complaining of long COVID. I think we'll get to, in the parking lot, we'll get to discuss a lot about this. I tend not to see a lot of long COVID, maybe depending on where I practice. But I think in the parking lot, we can talk a lot more about this. But it's a serious problem, as you raised, and there are few solutions.
Okay, thank you for the updates, Dr. Foma, and thank you, Brian, for emphasizing those additional points. I think it's about time we bring in our speaker for today. And I actually personally feel very small to introduce Professor Tambe, but we will take a shot at it, and hopefully we will be able to succinctly cover the wide, broad spectrum of his expertise. So Professor Tambe, with regards to his background, his academic training, obtained his medical degree from the Faculty of Medicine and Biomedical Sciences of the University of Yaoundé 1. After training in medicine, he went further to specialize in clinical radiology at the University of 1 as well, and obtained a master's in public health from the Université Libre de Brussels in Belgium. His clinical and public health experience has been quite extensive, and we are just going to highlight a few of the key experiences that have shaped his career so far. He worked as a physician at the regional hospital in Garoua when he came straight out of school, with emphasis in the internal medicine, emergency units, HIV and AIDS units, as well as TB care. He's equally affiliated as a researcher with the Center for the Development of Best Practices in Health, and is currently the head of department for the Medical Imaging Center at the Regional Hospital in Limbe. Dr. Tambe works currently full-time as a physician scientist, training the next generation of clinicians, and he lectures at the University of Boya as a full-time lecturer. Dr. Tambe today is going to be talking to us about medical imaging, and the title of his session is Ionizing Radiation Used in Medical Imaging in Cameroon, How Concerned Should We Be? Welcome, Dr. Tambe.
Thank you very much, Alison. The welcome is very warm, and at one point I was really wondering if it was me that was being introduced like that. But it's a very great honor for me to take up the challenge to be able to share something on our topic for today. Thank you very much.
Thank you, Doc. I think hopefully you should be able to share your screen. Just let us know if it looks good on your side.
that okay?
Yes, Doc, it looks great.
All right, thank you very much. I'm going to do a presentation on the subject I captioned, ionizing radiation use in medical imaging in Cameroon. How concerned should we be? Sorry, I have an issue with my video. Just a minute. All right, so I'm going to move on. Firstly, I must say that I have no conflict of interest to disclose. And as you could see on the title slide, all the views that are going to be expressed are the views of the presenter and not necessarily the institutions to which I'm affiliated to. Over the months that this town hall has been organized, the principal target audience is healthcare professionals. But recently we have all persons with stake or interest in healthcare, from patients to lay people. And so that makes it very difficult to give a presentation, given that the background is so diverse. But nevertheless, I decided to use a very classical approach to look at some of the very basics of ionizing radiation, a review such that somebody without a medical background should be able to understand. And so I therefore formulated some few pedagogic objectives. Don't bother about the words. If you're not from a medical background, we'll make it as simple as possible. So I expect you at the end of this presentation to be able to know what ionizing radiation is all about, to be able to list at least 3 sources of exposure to ionizing radiation, to be able to contrast between the 2 main effects, biological effects of ionizing radiation, and lastly, to be able to appraise the challenges to the appropriate use of medical imaging within the Cameroonian health system. So we're going to use the following outline. So for our introduction, ionizing radiation is simply energy. And this can be in the form of photons. We're talking of electromagnetic waves such as X-rays and gamma rays, or in the form of particles. But then this energy must be sufficient enough to ionize matter. And when we talk about ionization, there is a small equation on the screen. We see a form of energy splitting up a water molecule into the H plus and OH minus. Again, a lot of physics. But why is it important for us to know about ionizing radiation? It's because there are actually a variety of applications, from medicine, industry, security posts at the airport, across borders. So we have a variety of applications of ionizing radiation, and the effects are just so real. What can be more real to a patient than moving into a health facility for a complaint, and then you visit a radiology department, and you come out with a chest X-ray with a diagnosis of your condition. So, despite the fact that the applications are many, ionizing radiation is an established carcinogen. And the first reports of leukemia in radiologists was reported as early as 1943 in the medical literature. So we have every reason to be concerned about ionizing radiation. And another reason is because the sources are just everywhere around us. They are part of our everyday life, and sometimes we can't really avoid getting exposed to ionizing radiation. So for the presentation of today, our focus is going to be on a review of some concepts in radiobiology, just to make it simple so that anybody without a medical background should understand what we are talking about. We're going to be looking at the effects of ionizing radiation that is attributed to medical imaging. And we are going to look at the various ways in which we protect our clients in the hospital setting from the effects of ionizing radiation. At this point, let me position myself and provide a theoretical lens through which I believe this presentation should be viewed. And I'm taking the stance of risk communication, in which the objective is essentially to alert of the potential harmful consequences of something, and also to be able to reassure. I think that is a very key information with regards to the presentation of today. So how can we be exposed to ionizing radiation? Three main: environmental, medical, and occupational. And as can be seen from the slide, we see that there are just so many devices, just so many ways, part of our everyday life. These are sources of radiation. And interestingly, we have a red line in the middle that separates the figure. On this side, on the left, are what we call ionizing radiations, and to the right, these are non-ionizing radiation. And we see the sun actually sitting in the middle. The sun is going to give us what we call visible light in proper physics, with the red, orange, yellow, green, blue, indigo, and violet. And we also have ultraviolet rays, which are actually ionizing. Don't forget, ionizing simply means this photon or particle has sufficient energy to be able to split some molecules into free radicals. So if you look keenly at the image, I'm sure it's obvious that all of us are exposed either on a daily basis or as a necessary exposure arising from a medical problem. Now, a brief review of the electromagnetic spectrum. So to the left of the image, we have amplitude modulation, FM, frequency modulation from our TV and radio posts. We even have our cell phones, much of the Wi-Fi we have, our radars, TV remotes, light bulb with a visible light, ultraviolet, X-rays, and gamma. So to the left, these are waves of low energy. So they have a very long wavelength and a low frequency, and therefore the energy is low. These are considered to be non-ionizing. That means the energy is usually not sufficient enough to split molecules within biological tissues. To the right, we have shorter wavelengths, higher frequencies, and therefore higher energies. And this implies these rays, any substance that produces rays on the right side of the spectrum is capable of splitting biological molecules and producing free radicals. And we therefore describe this kind of energy as ionizing. Now, natural sources typically make up 50% of ionizing radiation. But essentially, medical sources are actually in competition, accounting for 48 to 50%. That's data from the National Radiation Protection Committee. And of the medical sources, computed tomography alone accounts for 50% of all medical sources of ionizing radiation. And we have other sources, medical sources, nuclear medicine, fluoroscopy, conventional radiography. And talking about the medical use of ionizing radiation, it is obvious that more and more CT equipment is more accessible. Centers that didn't used to have many years back are now being able to purchase. So we have kind of an increase in access to imaging technology, and especially technologies that use ionizing radiation. As can be seen from the graph, this is the situation of the United States of America. We can see the increase, the steady increase in the use of CT, both hospital and out of hospital use of CT. And the image to the right, we can actually compare the proportion of the use of CT and natural occurrence of radiation. We see that in the US, it's pretty a 50% ratio. Now, for the environmental exposure, I'm sure some of us are actually going to be surprised to find out that natural background radiation is virtually everywhere. As you can see from the small image to the right, a family in a garden. Of course, they should be having a nice time, and we use the word bio in Cameroon when you stay in a natural environment. But even our natural environment, believe me, are also sources of radiation. For example, there are terrestrial sources from the rocks and soil in the air we breathe, such as radon gas from plants, from food, and there are even radionuclides in the food we eat and also from the cosmic rays. We can also have ionizing radiation from man-made equipment such as nuclear weapons or nuclear accidents. And then we have industrial activities, which are all sources of ionizing radiation. For the medical exposures, we have diagnostic procedures such as computer tomography, nuclear medicine. Top right, that is a CT scanner of Regional Hospital Limbe. In the middle, that's an interventional procedure. And lastly, we have radiotherapy. Now, for occupational exposures, we have workers in nuclear plants and miners, and a very important group who are healthcare professionals. Now, the image further quantifies and compares the amount of radiation dose that can be absorbed based on where you are. For example, if you live around a nuclear plant, this is what you get. It's kind of negligible. And if you are high up, high elevation, such as in Denver in the US, we see that the background radiation is actually higher than those who live at sea level, almost 3 times higher. And for medical equipment, total body CT can produce as high as 10 millisieverts. And for the other procedures, we have a plain film of the abdomen, a single procedure head CT, a mammogram, but these are typically kind of negligible compared with background radiation. And we are going to see further the equivalent in terms of background radiation. For example, in most of our health facilities, the most frequent study that is requested remains the chest radiograph. I did a study some years back and it accounted for 48% of every single activity in the radiology department. But this is the deal. A chest radiograph for an adult is the equivalent of 3 days of natural radiation. Interestingly, the radiograph of the lumbar spine, which is usually second to the chest radiograph, is equivalent to 14 months of natural radiation. And then we have a plain abdominal film, which we typically request when we suspect bowel obstruction, bowel perforation. Some people call it a KUB film when they suspect a renal colic. But then the equivalent period of exposure is 9 months. So doing a single plain abdominal radiograph is equivalent of 9 months of natural radiation exposure. The brain scan typically is the most frequent cross-sectional imaging, and a single brain scan for an adult is equivalent of 300 days of natural radiation or 100 chest x-rays. So before we get into radiation protection proper, we'll review the biological effects. Let's see how this form of energy with so many beneficial effects and used in so many disciplines, how they produce biological effects or health effects, reason for which we are compelled to apply measures to protect ourselves from rays. Not to frighten anyone, but I'll begin with this quote from Albert Einstein. He admonishes that we have to make everything as simple as possible, but not so simple such that the real meaning is actually lost. So there are 2 main pathways in which ionizing radiation produces biological effects. In 2/3 of cases, it follows what we call the indirect pathway, and in 1/3 of cases, it follows what we call the direct pathway. Now, the subcellular target for ionizing radiation in biological tissues is the DNA. I have to state that very, very clearly because that is where it all happens with ionizing radiation. For the indirect pathway, once ionizing radiation, be it your alpha, beta, X-rays, gamma rays, once these rays get into living tissues, they produce what we call a reactive oxygen or a reactive nitrogen species. Big words there, but don't bother much. Just think of a small equation I gave at the beginning of the slides with energy splitting a water molecule and producing H plus and OH minus. These are called free radicals. So an example, we have the hydroxy radical, the nitroxy radical, the superoxide, hydrogen peroxide. These are all species that are capable of having an effect directly on the DNA. Now, for the direct pathway, the photon itself or the particle is capable of having a direct effect on the DNA without necessarily ionizing some molecules. Now, what is a typical effect? Two main. First is going to be a direct, there can be a direct DNA damage. You can have a single strand break or a double strand break. And the double strand breaks are typically very difficult to repair, but interestingly, there are fewer. The single strand breaks are very, very frequent, but easier to repair. We can have DNA cross-links, DNA protein cross-links, modification of the deoxyribose rings and bases. And if there isn't a direct damage to the DNA, we can have epigenetic effects, typically methylation of the DNA or histone modification. Well, what typically happens is the DNA sequence remains intact, but there are changes to the chromosome, such as in methylation. And then we now have expressions which are phenotypic, and while the DNA sequence actually remains the same. So now, once we have this effect, damage to DNA or the epigenetic effects, this can proceed to DNA repair in most cases. The DNA is completely repaired without any sequelae. Secondly, the cell may be unable to repair the damage to the DNA, and that leads to cell death. Now, if the cell doesn't die and there is an imperfect repair of the damage to the DNA, that's going to lead to mutations when this cell is going to undergo other forms of transformations. And lastly, we have epigenetic modifications, which are typically phenotypic changes in the gene expression. As I said, in epigenetic modification, the gene sequences typically remain the same, but then the phenotypic expressions are different because if a methyl group attaches to a base, it's going to change the gene expression, but nevertheless, the gene sequence remains the same. All right, that is just part of the biological effects or damage that can occur to the cell as a result of ionizing radiation. But from the diagram, we have so many other possibilities. Besides DNA damage that we're just talking about extensively, we have cell death and senescence, that's apoptosis, radiation-induced apoptosis. And then there are inflammasome, cellular stress, bystander effect, hypoxia, immune cell response. I wouldn't bother anybody with all of these, but it shows that radiation goes a long way to cause a lot of changes in the body. In as much as we use them for images, in as much as we use them to scan at the airport, security, atomic energy, and other aspects of application, but then they can produce a whole lot of effects, a spectrum of effects within the human body. And now some of them are used for diagnostic purposes, and some of these effects, the anti-inflammatory effects and cell death, are used in radiotherapy to treat cancer. The specific effect that an ionizing radiation is going to have on body tissues depends on three main factors. These are the type of radiation. LET stands for linear energy transfer, RBE, relative biological effectiveness. depends on the dose received, and it depends on the body tissue that is actually being irradiated. The body tissues do not respond to radiation in the same way. Some are very resistant, while some are very, very sensitive. So the same amount of energy to the body is going to produce different effects because these tissues respond differently to radiation. As can be seen from the table, we see that X-rays and gamma rays typically have a relative biological effectiveness of 1 compared to bigger particles such as the alpha and the beta particles. What does that imply? It implies the alpha and the beta particles are going to produce more ionization when they go through biological tissues, and they also are more likely to produce more double-strand breaks, which are more difficult to repair compared to the X-rays and the gamma rays. So X-ray and gamma rays will ionize less in biological tissues, and they're also going to produce more of single-strand breaks, which are easy to repair through cell repair mechanisms. So we go straight to the 2 main effects of ionizing radiation in biological tissues. The first are what we call the deterministic effects. There are 2 deterministic and stochastic effects. For the deterministic effects, big words again, don't bother much, retain what you can. But deterministic effects typically occur when many cells are going to lose their function and eventually die as a result of ionizing radiation. And this simultaneously occurs both at the cellular level and at the tissue level. So we have this effect during an acute exposure, so within a few hours or within a few days, and the actual dose received has to be above a certain threshold value. Typically for deterministic effects, the severity of the effects increases as the dose of radiation increases. And we typically get deterministic effects from high dose procedures such as interventional procedures or radiotherapy. As we can see from the images on the slide, these are burns on the hands. It was very, very common with the first radiologists. Some of them actually used to test if their equipment was working with their palm before actually doing a radiograph for a patient. So many of them ended up with either with skin lesions, which were deterministic, and some even developed stochastic radiation-induced cancers. But these, for example, are burns, which are radiation-induced, and the same thing on the back. So for the kind of effects we can have, typically these are the non-cancerous skin lesions, erythema, burns, radiation syndromes, which can be cutaneous, hematopoietic, gastrointestinal, and CNS. We have epilation. There is also an impact on fertility, but I had a good slide on that, but I didn't want to make the presentation too cumbersome. And deterministic effects can lead to congenital malformations and mental retardation. It's going to cause some fear, and I nevertheless decided to produce a slide to that effect to be more explicit. What happens when a woman is pregnant and has to go through an imaging procedure? Often, we are very, very cautious if we have to use any imaging modality that uses ionizing radiation on a woman of reproductive age, especially if she is pregnant. Now, let's look at the first scenario. From fertilization to day 8, that's on the left of my screen. From fertilization to day 8, what happens? We have an interesting cell, well, not a cell per se. The morula typically contains 16 cells, and it is described as totipotent. So the fertilized zygote now multiplies from the 1 cell to 4 cells to 8 cells, and then to 16 cells. What happens with the morula is that the cells are totipotent. It means a single cell has a capacity to divide and produce an entire organism just from a single cell. So if radiation is administered to this early pregnancy at a dose that is sufficient to cause cell death, 2 things. Either the pregnancy continues as though nothing happened, or the pregnancy is terminated. And that is what we call the all or nothing law. How does that play out? It simply means that one cell is capable of producing an entire organism. So if the X-rays do not kill all of the 16 and only one survives, the one cell that survives is going to produce an entire organism. That's the baby. If all the cells are killed by the rays, the pregnancy stops, and it can be one of the causes for the so-called spontaneous abortions that we have on the blighted ovum in clinical practice. Now, between day 9 to 9 weeks, that's a period where the organs are being formed, and that is a period of maximum radio sensitivity because the cells now are differentiated, and any death of cells in sufficient number is going to lead to a severe malformation. So if you have to administer ionizing radiation to a woman, you have to make sure, find out if she's pregnant or not, because if you inadvertently administer sufficient doses of ionizing radiation at this stage of pregnancy, then we are going to risk a severe malformation as a result of our procedure. And below we have the threshold of a dose that is capable of producing this effect. And between week 9 to 9 months is a period of fetal maturation. We can have minor malformations at this stage, but essentially the key period is between week 9 to week 15, where the brain is being organized. So you can have mental retardation, you can have problems with neuronal migration. There's just a whole a plethora of syndrome that we can get if radiation is carelessly given at this stage of pregnancy. The next effects that we can get besides the deterministic effects, which, as I said, they usually show up after a certain threshold of dose. Below the threshold, they don't show up. But after greater than the threshold, these effects are very, very likely to occur. And the severity of the effect increases with the dose. For the stochastic effects, stochastic simply means random. It's a big word. These are random effects, and it's actually the effect of radiation on a single cell. The deterministic, typically we need a group of cells, and often at a tissue level, because this will be sufficient enough to cause loss of function or cell or death of the organism. But for stochastic effects or the random effects, is the effect of radiation on a single cell. Now, this cell must not die. So the cell survives. It's a typical scenario if you have a DNA damage and the cell repairs the DNA, but it produces an imperfect copy. So the reparation process is not perfect. So we have cell damage, the DNA is repaired, but the repair is defective. Once this cell has to undergo, be it a mitotic or a meiotic transformation, is going to lead to a mutation, and that can lead to a cancer or other forms of heritable diseases. Now, the probability of the effect of the stochastic effect is related to the dose and not the severity. So that means if I give a very high dose, the chances of having cancer is likely. It's more likely than if I give a small dose. And there is no threshold beneath which the stochastic effects are not perceived to occur, which is why we are very, very concerned. If we were sure that above a certain or below a certain dose, we are completely free, nothing will go wrong, we can use our studies the way we like, but that is not the case. There is just no dose threshold below which we are very free and sure that our the imaging modality we are using is completely harmless. But studies have shown that these effects are less likely at a dose of less than 100 millisieverts. I just gave a table where we saw the effective doses of the different studies. And another thing interesting to note is that the cancers which are radiation induced, they are typically indistinguishable from other forms of cancer. So we cannot, there are no specific biomarkers or specific clinical or biological or morphological characteristics that may help us attribute a particular cancer to the radiation. So just a word regarding the pediatric population. We saw what happens in pregnancy. Now, for the pediatric population, we are very, very cautious for the following reasons. Children typically have a smaller body volume. And the idea with radiation is a given amount of energy is absorbed by a given volume of tissue. And the volume of children is typically smaller than that of adults. So if I have to give an energy, let's say 10 joules of energy, if you take 10 joules per kilogram for an adult who is 70 kilograms and 10 joules per kilogram for a child who is 5 kilograms, we see that it's not actually going to be the same thing. Secondly, children have very, very fragile tissues. Fragile tissues, they have a high proportion of young cells, they are actively growing, and they have a longer lifespan for which the effects can manifest. So to summarize the biological effects, we said that the DNA is a subcellular target for ionizing radiation, and we can have the damage to DNA through an indirect mechanism, that's the production of free radicals, which are typically called reactive oxygen or reactive nitrogen species, or the molecules or the particles can directly damage the DNA. And secondly, we can have epigenetic modifications, which are alterations of gene expression. Interestingly, DNA repair will occur most of the time, and the lesions that cause cell death, the proportion is actually small. A last word on the biological effects is that the manifestation of these effects is probabilistic. So we are dealing with probabilities. So going to the last part of our presentation on radiation protection and the challenges we face in the Cameroonian health system. I'll begin by explaining what it is all about, and as defined by the International Agency for Atomic Energy. Radiation protection seeks to protect people from the harmful effects of ionizing radiation. Simply put, but the International Labour Organization goes further. It acknowledges the fact that we have to protect humans from ionizing radiation, but nevertheless, not preventing them from benefiting from the positive aspects of ionizing radiation. Now, a bit of radiation epidemiology so that we can actually understand why we need radiation protection. It's because, as we said, these rays can do a lot of damage to the body, and we saw the risk factors which are linked to the rays, for example, the type of radiation in terms of linear energy transfer and the relative biological effectiveness, the amount of dose administered to the body, the particular body tissue type that is irradiated, the age at exposure, the sex, women are more predisposed, and it's also known that there is a genetic predisposition for cancer. But for most diagnostic imaging procedures, the risk of adverse effects of ionizing radiation is low, but it is never zero. And as Geoffrey Rose, a British epidemiologist, puts it, if we have to expose a large number of people to a small risk, it's going to lead to an increase in the number of cases in the population over time. All right, so this is the risk estimate for cancer as published by the National Cancer Institute of the United States. Our dose threshold is 100 milligrays. So we see that at this threshold of 100 milligrays, diagnostic imaging actually transcends. So we have some studies that are less than 100 milligray, and we also have other studies that are capable of delivering radiation doses in diagnostic imaging greater than the threshold of 100 milligray. Now, when it comes to therapeutic use of the rays, as in radiotherapy or radiation therapy or radiation oncology, we actually see that the doses are very high. And the threshold of 100 milligray has actually been confirmed by multiple studies. So for the cancers that are typically associated with radiation, this has been validated by so many studies. It is interesting, let me just put in a caveat here to say that ethically, we cannot carry out studies on the effects of ionizing radiation on human subjects in real time. Of course, we cannot intentionally radiate people and then measure the effects. So for ethical reasons, we have to use epidemiological studies. And one of the best sources of evidence has been studies of survivors of the atomic bomb in Japan, in Nagasaki and Hiroshima. And then the data of patients who have been subjected to multiple repeat imaging studies over time has been exploited in case control studies, mostly nested case control studies, to be able to compare with people of the similar age and sex within the same period of time. And the incidence of these cancers have been actually compared. And once that has been done, there is compelling evidence that the following cancers are linked to radiation. These are bladder cancer, breast, the lung, leukemia, brain, ovary, thyroid, the colon, the esophagus, the liver, and the bone. Now, for some other cancer types, the evidence is not strong enough. That's why it is possibly associated, and for some, it's quite unclear. Okay, I'll just explain some concepts in epidemiology, or what I'll call radiation epidemiology. Anybody who is familiar with basic clinical epidemiology has basic notion of the concepts of causation and attribution. It's very, very important to our topic when we talk of cause and effect, especially with radiation producing certain effects in humans. So if we have a certain factor A, which can be an event or set of conditions, that is necessary for outcome B to occur, then we can say that factor A is a cause of outcome B. That is, whenever A occurs and B is going to follow. Now, that's the definition of causation that is mostly employed as it stands. But in radiation epidemiology, we have actually extended this definition not to cover just actual occurrence of A followed by the occurrence of B, but that there is the probability. So we have added a probabilistic component that the presence of A has a high probability that B is going to occur. So that's how we look at causation. But nevertheless, in epidemiology, we have the Bradford-Hill guidelines. I would recommend anybody who is interested to check on that. For us to talk on causation, there is a set of guidelines. For example, there is a temporal sequence. The exposure must precede the outcome. And then we have biological plausibility. It's true, it's limited by knowledge, but there should be some kind of possible explanation how the two can be related. And then we have the strength of the association. We have consistency, so that each time one is present, the other has to be there. And specificity also. So a specific factor has to be associated with a specific outcome and not a multiple heterogeneous group of outcomes. So let's take a simple scenario. If our factor A is the poliovirus and the outcome is poliomyelitis, the question I'm going to ask is, can outcome B, which is poliomyelitis, occur in the absence of the poliovirus? That is the counter counterfactual analysis reasoning. If the answer is no, then that simply implies that poliovirus is the cause for poliomyelitis. Okay, I'll take another example. If a factor is smoking, whatever the number of pack years, and the specific outcome in a patient is lung cancer. So we have a patient who smokes and then ends up with a lung cancer. Now, in applying the counterfactual analysis reasoning, I'm going to ask the question, could this lung cancer have occurred if our patient never smoked? If the answer is yes, that simply means that we cannot completely ascribe smoking as the cause of our patient's lung cancer, and other conditions could have been responsible for the patient's lung cancer. So smoking could just have contributed or worked in concert with other factors to produce the outcome. So that is the way we interpret or we look at the effects of radiation and its effects. We're always going to ask the question, if the patient did not receive the radiation, could that particular cancer have developed? And we can now, if the answer is yes, it means the radiation probably was not a sufficient cause for the cancer to develop. And so we move into other calculations like the attributable fraction to be able to determine the proportion of occurrence of the condition that can be ascribed to the given factor. In this case, our factor is radiation. So we have seen what it is. We have seen why radiation protection. Now the question is how. There are three main ways in which we protect our patients. The first is JOL. It's an acronym, JOL, J for justification, O for optimization, and L for limitation. For justification, the principle of justification states that for any study that we prescribe for a patient that uses ionizing radiation, the benefits must outweigh the risk. We must explain that to our patient, and we must make sure that is the case. And it is usually the duty of the consultant radiologist to enforce that aspect of radiation protection in the clinical setting. And second is optimization. Optimization simply means we are using the best study protocol to be able to answer a clinical question. In that case, we minimize the amount of radiation dose or radiation energy that we deliver to a patient during a study. For example, you have a patient and you suspect a kidney stone. What do? Do you ask for a CT scan, on an enhanced CT scan, or do you ask at once for a CT urogram? Of course, the findings are not going to be the same. So for the limitation, it applies to health professionals who work directly with ionizing radiation. There is a maximum authorized dose that a worker is supposed to receive within a year or within a 5-year period. If occupational exposure is above 100 millisieverts in 5 years, again, that's our threshold for most of our effects, this worker is withdrawn from the exposure, from the occupational exposure. Or if a particular worker goes up to 50 millisieverts within a year, within 12 months, the worker is withdrawn from exposure. Now, in our context, what typically happens? We have a problem with the way equipment are being acquired and set up in many different facilities. In our Cameroonian health system, we need an authorization to be able to create a facility. Whatever health facility, we need an authorization. And if we need to use devices that use ionizing radiation, we need special authorizations. But we have a problem with the way this equipment is often acquired. Often these are second-handed equipment which have been dismantled from stronger economies and sent to Africa to help us. But then we don't have a way of ascertaining if these equipment are still accredited for use. And we typically do not have the means of assuring a continuous quality control of this equipment, because once they are built and used for a certain number of years, they start to malfunction and maintenance become very, very costly. Often that's the reason why some of them are actually dismantled and sent to Africa. We have weaker regulations here so they can go through. The next thing is the infrastructures. Most of the infrastructures that we have do not respect the norms. Believe me, as a radiologist working with ionizing radiation, the room where these equipment are located needs to be built with specific materials and in specific ways. Otherwise, it's going to be a festival of rays in every direction and everywhere when a study is being done. So imagine that you have an office next to a CT room, and if the infrastructure was not built taking into account the norms, the rays are going to go through the walls and meet you in the office. So we have a problem with infrastructure. Many people don't respect the norms. And another problem with location. For commercial purposes, people set up cabinets everywhere. So you have a particular building that was actually developed for commercial purposes. Somebody puts a CT scanner on the second floor. There is a bank on the first floor. On top of him, we have offices, maybe a lawyer's office and many other kind of offices or work places. And then we have people living around. But what about the norms? The building was not designed typically to host such kind of equipment. I'm not saying some people don't do. There are very few centers I've actually been to that go through the norm to make sure that the walls are sealed, to make sure that there is lead is used everywhere, so that it can, of a certain thickness, not just using lead, but of a certain thickness. And controls are done to make sure that the rays do not go through. Another big challenge we have is that so many people who use ionizing radiation in our setting, they are not trained formally. Most promoters of health facility are even non-medical personnel. Some of them train on the job training, and it's easy to show somebody how to do a chest X-ray, for example, and within a few weeks they are already operational. And even some of the staff who have gone through formal training still really have insufficient knowledge on radiation protection, and that affects the way in which the equipment are being used. A big problem is that there are actually a lot of lapses with our training, as some of our studies, I'm going to show that later, the next slide rather, have shown that so many requesting physicians have difficulties prescribing some imaging studies because they don't know the diagnostic yield of particular studies. What is the best study I'm going to request for my patient in a particular situation? And often you have a nurse working alone, an assistant nurse working alone, a general practitioner somewhere, set up somewhere and working alone. And they don't have the resources, they don't have the knowledge. So they don't master the indications and they prescribe. The health system in Cameroon does not provide for consultant vetting of request forms. In other health systems based on the payer systems that are in force, you cannot do any kind of prescription and it goes through without being vetted. Otherwise, you don't get any reimbursement for that. And nobody will even do it knowing fully well that it's not going to be reimbursed. So we have a problem of financial conflict of interest. People request studies, a CT scan or whatever X-rays, whereas they may not really be needed simply because of financial conflict of interest. The more you prescribe, the more money you get, the more money you work, or as a radiologist, the more studies you do. If you are paid on a pay-as-you-go basis, the more studies you do, the more money you have. And therefore, the financial conflict of interest doesn't enable us at times to actually curb the excessive and often inappropriate use of imaging technology. And we also have few imaging specialists with a very high workload. So typically in my practice, I don't get to see all the x-rays which are requested, all the forms before vetting for them to be done. I don't get to see all the CT scans, all the forms that are requested. I have to trust my technologists to assess the forms and then get this, the study done. So at times I come to interpret studies, and when I pick up the form, my first reaction is, oh my God, what is this? This study was not indicated, and this study is capable of delivering high doses of ionizing radiation. Now, if this is a child, if this is a pregnant woman or a lady of reproductive age, I'm even more worried, because I know the effect it can have in the long run. So we also have the practice of self-referrals. People come by themselves. I want to do a chest x-ray, I have cough and I think I need one. I just need a scan. I've been having some pain in my abdomen. I just wanted to scan my body, let me know what is wrong. And at times, some of the people who do that are people who are financially viable. They can pay for it. Some of them actually have some sort of financial protection for health, that is a health insurance, and they want to make use of it at all costs. So these are patients who are more likely to pressure practitioners to prescribe studies for them. And then we also have the enthusiasm to use a high-end medical equipment. You know, we have a new equipment, it's 16 slides, 32 slides, it's the talk of the town, and everybody is excited. And people want to discover. So, you know, people say, okay, I now want to practice good medicine. And that means anytime you see a patient who may need something that you have read about in your textbook, you just go ahead and you do a prescription. Another reason is defensive medicine. That's more common in high income settings, where lawsuits are the order of the day, and there's always the question, what if I don't do it and the patient comes back some weeks back, some months after rather, with a subdural hematoma. So in order to protect the referring physician, in order to protect himself, he feels like he has to hide behind a prescription. At times it works, but at times we already know that the study is going to be normal. But the problem is not having a normal study. A normal study can be a very good finding. We are talking of inappropriate studies when the findings typically do not contribute in patient care. That's what we describe as an inappropriate study. It has not helped the patient or the clinician in any way. And then we have effective marketing strategy for manufacturers. Let's not forget, we often say that technology has come to develop healthcare a lot. I agree with that 100%. But then let's not also forget that often or oftentimes, the health sector is rather perceived as a market for technology. So people look at the health sector as an area with enormous opportunities. People were always going to be sick, disease will always hang around. So you harness technology in that domain. And because of that, the people in industries, they easily convince clinicians of the benefits of their products, and at times too, we get into conflict of interest and we have to use this technology. So if their marketing strategies at times are very, very effective, we fall in the trap of manufacturers. So the slide just shows some of the studies that we have been able to do on radiation protection, knowledge of radiation protection in Cameroon. I can recall the top left is my very, very first publication as a resident, where we looked at routine chest radiograph in students who were vying for a place at a state university. And of course, 98% of the radiographs were normal because the students were asymptomatic, and just the 2% that were symptomatic had some mild findings. So our conclusion was that this study can be reserved for people who are symptomatic and not just for everybody, especially given that at that age, they don't have a long history of so many things. In an adult population, that would have been a bit more different. And in the publication in the middle, we looked at the patterns of use of computed tomography in patients with health insurance and compared with those who didn't have. And we find that there was more inappropriate use of CT technology in patients with health insurance, and the reasons are obvious. So some studies carried out in Yaoundé by one of my supervisors, Professor Boniface Mwafo, we actually worked with referring physicians, and it was obvious that so many of our doctors, so many of our colleagues, they don't know how to actually fill request forms for exams. And they also don't know about the ionizing, about the effects, biological effects of ionizing radiation. Of course, if they are not taught, they wouldn't know. If clerkship is not done in the radiology department, they wouldn't know. Then we have also looked at, okay, this one was done in Douala. And of course, comparing Douala and Limbe on the extreme right, we had more inappropriate scans in our study site in Douala compared to what we obtained in Limbe. So we have collaborated in other studies with aim to produce diagnostic reference levels in our setting. A word about the National Radiation Protection Agency before I stop. This is actually an agency whose role is to control the use of all sources of ionizing radiation in Cameroon. The headquarters is in Yaoundé. I'm sure this was created around 2011 or 12 or so. And it's typically made up of physicists, technologists, and many other people, but unfortunately, we don't find radiologists as part of this group. They only come and work with radiologists in the health facilities. And typically, from a clinician's perspective, I've received them a couple of times when they come to do periodic checks on the state of the equipment in the health facilities. And then they give recommendations. But then they cannot sanction any facilities, especially public facilities. And a small anecdote, I used an equipment when I just left school as a radiologist. This equipment was installed in the 1960s and was still functional. Interestingly, if you have to do a radiograph of the chest, of the spine, of the abdomen, of the limbs or the joints, this equipment gives you a fixed dose, which is typically not the case in clinical practice. If you have a smaller region, you have to minimize the dose. If you have, okay, like the abdomen or the chest, the dose is typically higher. But we didn't know, we had been working with the equipment for a long time, and we didn't know until we had the surprise visit, and they recommended we get a new machine. But they recommending you get a new machine and for management to mobilize the resources to get a machine is something else. But nevertheless, they exist, and that is their role, to control all sources of ionizing radiation. I'm going to conclude this presentation still with my key points by saying that more and more we have an increase in exposure to ionizing radiation. And the medical sources are actually on par with the natural sources. The effects are real. We saw the deterministic and the stochastic effects. And the probability of having these effects actually increases typically with the dose for so many. Don't be afraid. The effects are not so many. But nevertheless, we have to be careful, because even if it's 1%, if the radiation-induced cancer, it's not going to be funny. So we have to minimize unnecessary exposure to ionizing radiation. So we always have to ask ourselves the question, is the study really needed for my patient? If you are not sure, talk with another colleague, talk with a consultant. Find out, are there alternatives? You have to talk with your radiologist. And we also have to explain the risk to our clients. More and more, our clients are not as ignorant as they used to be. They have a lot of information, and often these informations are is kind of misinformation. It's our role as healthcare providers to give them the right information. Yes, the risk of ionizing radiation is real, but nevertheless, they can be negligible at certain doses. Probably for the dose we are going to use for your study, the risk is negligible, and the benefits typically are going to outweigh the risk. I end with this quote from Antoine Becler, a French radiologist, who said, "Les rayons de röntgen sont comme la lance d'Achille. Ils blessent et ils guérissent." Those in the US can put it in Google Translate and get a better translation into English. That's a view of Limbe from my balcony as I went out for sports this morning. Thank you very much, and over to you.
Oh, wow, Dr. Tambe, thank you. This was really, really enlightening. I wish I could just be clapping from this side. And the view from your balcony is beautiful, by the way. That's a lovely view. Probably all the inspiration is coming from that beautiful view and all the great work you're doing. Thank you for this great presentation. And Doug, maybe you might want to grab a glass of water, a cup of tea, because we're going to test the temperature. Yeah. You've been talking for over an hour. And I'm seeing some interesting, exciting faces in the town hall, whom I'm going to be calling on just to ask them how they feel about today's session. Dr. Stephen Tako. Hi, Stephen.
Hi, Doug. Greetings to everyone.
Welcome. We are so excited to have you. Would you maybe just tell us where you're joining us from and tell us how you found Dr. Tambe's session?
I'm joining you guys from Nairobi, Kenya, and it's been an extremely mind-blowing presentation. I used to think radiologists just do x-rays and CT scans, but I think they do much more. So I really enjoyed it. Thank you.
Thank you, Doc. We also have in the house Professor Dr. Dennis Nsame, who is the Regional Hospital of Bamenda's director. Dr. Nsame, are you here with us?
Yes, Alison, thank you very much. I've been listening, though joined a bit late, really in Abakwa town now. And I'm very happy, you know, when I actually saw that Joshua was coming up, I was so elated. And of course, we've been with Dr. Former for the past time, even though I actually was absent for many sessions already, but I could not help to miss this one. So, Alison, I'm so happy. And I'm happy to my radiologist. I could see Dr. Chin was part of it because we have just been talking about this National Radiation Protection Agency. Yeah, my staff in the imaging center of the Regional Hospital Bamenda actually were worried that why should the staff be working there? We did this application to the agency, and behold, we just received the contract to sign with a lot of, things inside. Oh, if you don't send the, the gadgets by this time, you're gonna have a 10% penalty, a lot of monies to pay, I think close to $1 million and things like that. It's quite good, which we wanted. But it wasn't like before. I remember with Dr. Tambe, when I was in Limbe, I think that was one of our main worries too. How do we protect the staff? Dr. Tambe, the chief of service of this unit. It's a big challenge. And maybe if I may just ask a question, Dr. Joshua has actually said it all. Now, most of these health facilities having all this radiation equipment, how do we protect the staff? Not forgetting the patients. I know that we have already, because all the dosimeters, we've not had dosimeters in Bamenda for quite, I don't know, more than 7 years or so. They're all expired. We just had the new ones now. They just came in. And even all the secretaries inside were having. When we saw the bill, we were so worried. Is that how we'll be spending? Meanwhile, we have only small prices, very affordable. We have, when the month ends, we must be in Douala at their office and then collect the gadgets, they read them, and then we collect new ones and come. So maybe Dr. Tambe will expatiate again on it. I'm happy Dr. Chin, my Chief of Service of Radiology, is also here. I'm so happy being with you. Bravo, I was so happy with this presentation. Thank you very much.
Thank you, Dr. Sami. We are excited to have you, and we're actually looking forward to engaging you in the near future around, having you join us here to talk about a topic of interest to you. And Dr. Chin, unfortunately, you can't run away from us anymore because your director has flagged to us that we have an expert in the house. So we will be coming for you in a bit. Our co-moderators, Therese and Zia, is going to be handling the Q&A session. And she has already just texted me. She's like, Alison, I'm going for Dr. Chin. So Dr. Chin, please grab your own cup of tea because it's going to be a lit house this afternoon. And lastly, before we begin the Q&A, I would like to call on Dr. Ferdinand Ndum just to tell us how he feels. Dr. Ferdinand Ndum is in the nuclear medicine space. Hi, Ferdi.
Hi, how are you?
How was today's session? How are you feeling today?
It was really good. I was for somebody who is also in the field, I was really impressed with the professor. He explained a lot of things in a very, very good way. Yeah, and I was very happy. I learned also a lot of things, and I look forward to the rest of this interaction.
Awesome. Thank you so much, Ferdi.
Yeah.
Teresa, how about this still?
Hi, everybody, and hi, everyone, and thank you guys for coming again today. And I'm excited to be with you guys here today. And before I start this Q&A, we're gonna get it real quick so we can catch up with our program. But let's first shout out a happy birthday to Dr. Chin. Hey, happy birthday.
Interesting. Hello, everybody.
Yeah.
Thank you very much. Thank you very much.
Yeah. Okay, let's just go to Q&A. We're gonna start with Ayok Foma. Ayok, can you ask a question? Hello?
Hello, everyone.
Oh, yeah, okay.
Can you hear me now?
Yes.
Okay, hello. My name is Dr. Ayuk Foma Mafomekong. As you can see, I'm Munot's sister. So I am more into drug toxicology and safety pharmacology. I'm a physician by profession, and I work in drug regulation in the United Kingdom. So I have this question is for Professor Tambe and all the other radiologists in the house, really, especially those working in Cameroon. I'm really concerned about radiopharmaceuticals and diagnostic agents. How do you source them in Cameroon? Who regulates them? And how are they disposed of? Because yes, we've talked about the patients, the harmful effect it has on the patients, the population, and everyone. But then how do we source these things? How do we dispose of them? Because we use them on a daily basis. How do we make sure that somebody who is passing on the street doesn't touch these things and the people who are touching them and disposing of them know what they're actually doing? And have we done any studies to actually find out the best ways of disposing of all these radiopharmaceutical agents? I'm just talking from a point of concern, because we've got people here who are patients, we've got people here who are reading a lot, and we need to know how these things are being taken care of. So thank you very much.
Thank you very much. Do I have the floor?
Yes, you do.
Yes, please.
Thank you very much. It's quite unfortunate I can't respond to your worries. We have a kind of a dichotomy between the radiology departments and the radiation oncology services where these radiopharmaceuticals are being used. So I don't work in the radiation oncology unit, and I really don't master the pathway in which how they actually procure and then dispose of the radiopharmaceuticals. But if I can get that information from a radiation oncologist, I wouldn't hesitate to get back to you.
Thank you.
Hello?
Yep.
Oh, okay. Yes. So we're gonna go to the next question. We hope we'll get like someone that can help us with that question in the house and get a session on that. And I think our chairman is gonna work on it so we can have some answers when needed. So let's go to Kwan Jacob.
Yeah, thank you. I'm Jacob. I'm based in Cameroon, and I'm working with the Cameroon Baptist Convention Health Services. I'm a nurse by training, and I'm actually focusing more on infection prevention and the WASH. I'm so happy about this session today. First, because our expert is based quite in Limbe, which means I can walk to him if I have any further, if I need any further details. Secondly, I'm also glad that Dr. Sami is here, who is also based here in Cameroon. So I have a team of people that can actually at least bear witness that we really need to do a lot as far as radiation safety is concerned. Doc, you raised some very key pertinent issues towards your conclusion. The issue of infrastructure and the issue of staff training. Let me begin with infrastructure. I remember some early days, I think 1998, when I just joined the system, I was trained in X-ray for 3 months. I really didn't know anything. But later on, when I understood that there need to be some specific standard of the department, I discovered that a lot of the departments or imaging department we have in the country do not meet these specifications. And then secondly, when we actually try to find out what it takes to do that, the cost was really very prohibitive. And I could not imagine, especially private organization, being able to do that. And then the question is, do we really stop them from doing imaging? Or do we allow them? I mean, I don't know. It's a very difficult thing. Then the second thing about training, and let me talk about even those who prescribe as well as those who expose. How many of them really have an idea, a knowledge about what you have said here today? So in fact, I really don't know where we will begin, but I really think that there is a very, very, very big problem. And I want to find out from you, are there any studies on ground that really have an idea about the standard, how many of our departments really meet the standard for imaging department, as well as the staff that are being that are exposing that are working in such departments. Thank you.
Thank you very much, Mr. Kwan Jacob. I'm happy you are my neighbor with the Baptist, so I think we can actually do a lot. I'll begin with the last aspect of your question, talking about statistics on departments which do not meet standards. I don't have that data, and I think it's going to be a Herculean task to be able to obtain one, because you first of all need to do a census of all units that use a device with ionizing radiation, especially medical imaging. Anywhere, any small health facility where ionizing radiation or chest x-rays are being done in general, you definitely need to have a list of them, and then you audit them. But how do you do that? That is a problem, because you're getting into somebody's privacy. Some of them don't have authorizations even to function, and it becomes very, very difficult. You're going to expose a very big systemic problem, and you will end up running into personal problems with people who may think that you are out to destabilize them or to shut them down. So that kind of a study is going to be very, very difficult. But an audit of the level of training of the staff in so many of our public facilities actually showed that a good number of the radiographers, these guys are doing a good job, and I have a lot of respect for them. A good number of them are trained on the job. And on the job training means we show them how to manipulate the equipment, and then we show them how to position the patient and get a view and get a good image. We show them how to clean the equipment, and it ends there. Now, much of the issues of X-rays, how they are produced, and physical properties and the effects. They don't know. And you need to see at times how these technicians themselves play with this equipment. Somebody tells you he's not afraid of what he doesn't see. Of course, nobody sees an X-ray. So, and they play with it, but I don't blame them for it. Their level of education, the level of training is not sufficient. And because we pick them and train them on the job and they can do the work for us, we pay them less, we are satisfied. So many health facilities stop at that level. And when it comes to positioning, believe me, I gave an example of an imaging unit that is in maybe somebody's house, that is out for let, and behind there are rooms. We have facilities like that. The walls were not designed to, I don't know, to contain that kind of an equipment. So nobody puts in the extra money to be actually put lead walls, to put lead shields and protect the environment. So it's a very, very difficult thing for us. And we can't stop anybody. That is why I think the town hall is very, very important, because we educate ourselves. Myself, I learn a lot from the town hall. Those who attend our sessions also get to learn a lot. And you can help somebody, you can share with somebody. And I think now if you move into any unit and somebody wants to do an X-ray for you for no reason, you will have to say, but wait, doctor, why are you asking me to do this? Is it really necessary? Because more and more we learn as the days go by. But going to audit these centers, believe me, that should be the job of a higher authority. There's nothing much that we can do. But it is clear that most of our practitioners do not have sufficient knowledge. And even some of our doctors who prescribe, and as I said, it's a problem, it's a training problem. You cannot study all of medicine in 6-7 years. And some aspects are actually overemphasized, while other aspects are completely neglected. Maybe we should open up channels for internship in other domains so that we can even get have an idea of what the other colleague does. Thank you.
Thank you so much, Dr. Tambe. I'm going to call on Dr. Jean-Claude Kate. Jean-Claude.
Yeah, thank you very much, Teresia. And I don't know where you are, but I was following your WhatsApp a while ago. I've been following the session on Facebook, and just to say that, yeah, and then I managed to join the Zoom call towards the end. So thank you, Dr. Tambe, Dr. Joshua Tambe, for that presentation. I've learned a lot. And in the same vein with regards to Mr. Kwan, I just want to ask, you know, there is this presidential will to set up imaging centers in all 10 regions in Cameroon. And I guess that has been done to a certain extent, if not to 100%, I don't know, in one way or the other. And you rightly mentioned about private owners of imaging centers. To the best of your knowledge, I don't know, what do you think about moving towards accreditation or some form of certification for these units? That's both for the public. Most of these units in public or in the regional hospitals, as you know, probably are well constructed, probably. I don't know much about the standards. How can we move private and even public towards these certifications? I don't know the specific ISO accreditation or certification that is needed. I don't know if you have any thoughts on that. And even with regards to your own center in Limbe, what do you think about moving your center probably to be the first center in Cameroon that has some form of ISO certification, and so push the rest of the nation to upholding this kind of standard? My second question is around now some biology. As you know, and many people might know, I work on diabetes, and I've been seeing a specific funny phenotype of diabetes as part of my projects where it doesn't really match up the main forms of diabetes that we've studied in school. And I'm thinking something environmental might be playing around. And just you watching your presentation today was maybe radiations. I don't know if you've had anything to read or to write around the effects on radiation on pancreas biology, and specifically with the islet cells, with the B cells. Can radiation cause specific damage to the B cells that would lead to severe insulin deficiency without any other form of I don't know, pancreatic disorder? I don't know. So I just wanted to bring that to your thoughts to on the table today. Yeah, thank you.
Thank you, Dr. Kati. Your second question, actually, probably I'm going to pick that up as my second PhD thesis. I'm actually a PhD candidate in clinical epidemiology, and you have just given me, I'm defense soon, so you have given me another topic. So immediately I defend, I'm going to pick up this one. So from my research, actually, I didn't pick up anything specifically for the pancreas, save for the fact that there is some evidence in the literature that some pancreatic tumors are radiation induced. Now, getting into the biological mechanisms of radiation, honestly, it's very, very interesting what radiation can do. There is a process called hormesis, Hormesis. That simply means in low doses, a substance that is potentially hazardous is rather going to have stimulatory effects, and at high doses is going to have inhibitory effects. Hormesis is typically associated with radiation. And in one of the slides with the radiation in the middle, and then I put a whole list of possible effects around, you got to see that the effects of radiation, they are multidimensional. Now, the aspect of radiation-induced cancers and the deterministic effects are essentially linked to DNA damage. But radiation also has an immune and an inflammatory response. There are also particles that are called inflammasomes, which are also stimulated and produced by radiation. So probably, as I said, I have to go back to that slide and just check on the different possible effects with radiation. And maybe we can have an idea if it's maybe through an immunologic pathway, if it's through an inflammatory pathway on the B cells. But as I said, the only association I got was that of cancer, and not maybe on the effects of the cells, and then leading to the specific type of diabetes that you report. But as I said, given the principle of hormesis, it becomes a possibility. But I've given my word, that will be my second PhD topic, so I've noted it down. And when it comes to certification and accreditation, Kati, I think that's a way forward in any serious system. If we intend to harmonize the level of quality and generalize that same standard to every health facility, then we need to do some sort of certification or accreditation. So I think that has been done for some laboratories, and they actually have an accreditation process. We may not be able to use the very rigorous international standards, but we may be able to develop local standards. Bekati, I'll be frank with you, it's going to be very, very difficult. I'll give you my experience. In the French health system, one of the things is you need to know is that this equipment, they have a kind of, their life is programmed, it's a kind of an apoptosis, because the X-ray tube dies and the manufacturer after 10 years no longer produces. The technology has shifted to another level. So you always have to be moving with the technology to meet up. So there, you use a scan for 5 years and the scan is no longer good to be used. Maybe it was an 8 detector scan. Now the technology has moved to 64, 128. Nobody goes again for an 8 detector scan, and this equipment are no longer being produced. So often they dismantled and sent to Africa. Now, in our context, we are very, very happy to have even a single detector scan in a place that is far away from our centers of Yaoundé and Douala. So Accreditation, good. It will help us a lot in Yaoundé, Douala, the big hospitals. But there is no way you can stop a facility that is in a remote area from functioning because of accreditation. It becomes now a very political decision to enforce. So you can do the paperwork. Yeah, you can select some few cardinal facilities and it works there. But there is no way you're able to enforce that once you go beyond the very big and autonomous institutions. Secondly, administrative bottlenecks too. It's a difficult thing. It's one thing to buy a brand new CT scan and you give, let's say, regional hospital Limbe. After 6 years, the scan is already having all kinds of problems, and given the way management is done within our health system, there is no money waiting somewhere. If it gets bad, you just take and buy and you put. So till the day it dies, you only have to do with what you have. And maybe I'll just throw in something for Dr. Dennis Same. Of course, he's a hospital manager and I worked with him. And at times we had to be fighting a lot when it comes to money to buy things. But I understand that it's an entire facility. Some services are going to generate money, some don't. But then you have a unit that is capable of generating money, but the essence is for community service. You have a single breakdown and you have to spend tens of millions for repair. And the prices too have to meet the level of life of the community. So if I have to do a scan at 30,000 or 50,000 francs and I have, let's say, 5 scans per day, and after maybe 3 months, 6 months, I have a breakdown that's going to cost 30 million. It's definitely not sustainable. So we have to draw the line between trying to be sustainable and reach everybody, and also trying to be very rigorous in terms of activity, in terms of scientific credibility. So Kate, as I said, but I'm very, very open to accreditation, but it's going to be very, very difficult in our setting, believe me. Thank you very much.
Thank you, Doc. I'm going to take the last 3 questions so we can wrap up real quick and catch up with our program. So I'm first going to call on Dr. Ferdinand to ask his question, and then we're going to go to Dr. Foma.
Okay, thanks for giving me the platform. I first wanted to make a little comment on what the professor said about hormesis. That's how you termed it, right?
Yeah.
We just make a joke because I work in the nuclear medicine in Germany, and in our department, we have some workers who have been working for 30 years old, and they are very strong. They don't have any health problems. Then we have a group of young doctors, early 30s, consultants and so on, who have young children, all very healthy. I mean, we're really, really healthy. And we're exposed to this while working with open radionuclides. So with gamma radiation, beta radiation, at times alpha radiation. And we usually joke that because we receive this radiation in little quantities every day, we have been we don't fall sick. Let me put it that way. It's a very strange thing. But notwithstanding, we have to be careful, and we have these dosimeters and so on. And the question I wanted to ask, by the way, was about dosimeters. How do you people keep track of the exposure, especially you, Professor Tambe, in your practice every day? How do you make sure that you have a record, or you keep track of how much radiation you receive? Do you have a dosimeter you have every time on you, or how do you do it? Is it every day? Is it an office which records at the end of the month or something, where it's measured somewhere? I don't know how it works with you people.
Thank you very much, Ferdinand. I'm happy you work in nuclear medicine, so you can help us with a lot of some of the questions that may show up. For my practice as a radiologist, I have never used a personal dosimeter. Never, never, never. As a resident, I had access to, because we were in some big hospitals that could afford, but in my practice, I've never had one for myself. Now, how does it play out? the state buys the equipment, and then you are posted to the facility, and they say, Mr. Radiologist, go ahead and work. All right, I need to work. I have to, but I have to protect myself. I need a dosimeter. I need this, I need that. We have the National Radiation Protection Agency, that is the organ in charge of dosimeters. So you actually write up a formal application to them. They come to the unit, and then they actually do the control checks and whatever. And based on the number of persons who are directly, whose activities are directly related with ionizing radiation, we are giving dosimeters. While at work, you wear them permanently because we are more concerned with occupational exposure. Then they are supposed to come in periodically to take the dosimeters and measure and then give you the reading. Now, as I said, we have applied in my facility once and we never had a feedback. And believe me, this is the reason. Maybe this information for the parking lot. We have a lot of administrative bottlenecks, and the organism or the institution that is in charge of that, you have to pay and register with them. And as Dr. Same opened up the caveat, you have to be paying them regularly for giving you dosimeters and for taking the dosimeters and doing your measurements and letting you know the amount of radiation energy to which you have been exposed. You pay for that. And who pays? The hospital management is expected to pay for that. And being a manager, you know, by the time you work some small amount of money and then somebody shows up, I've analyzed your dosimeter, you need to give me 3 million francs CFA. And the question is, how much have I worked for the facility to take 3 million francs and give to you just for that? So there is that inconsistency in the assessment of it. So the bottom line is we are not protected with dosimeters. So what I tell my technicians and what I do for myself is we use the basic principles of radiation protection. You make sure you are not in the field when a study is being done. You make sure you wear lead aprons if you have to do a study. And then you make sure that you are completely, when we do our routine checks, of course, we have an idea of our unit. We know if X-rays are extending beyond certain boundaries. That fact is known in the unit. So all what we can do is to limit our personal exposure to the field of X-ray. But in the unit, we really can't do that. So we don't have dosimeters, and it's unfortunate. As I said, much of the information will be for the parking lot.
Thank you very much.
We'll be happy to get it from you if you can help us, Ferdinand.
Thank you so much, Dr. Tame. Dr. Former, please.
Okay, so thank you very much. And yeah, Professor Tambe is my classmate, and I'm very proud of him. The presentation, as usual, was like a CME presentation. I've always said, I hope we can upgrade one day when people get to participate in the town hall and they get CME credit. This reminded me of my first day in radiation oncology. Even here in the US, I did internal medicine. I didn't come across any kind of education in radiation oncology till I started my fellowship in oncology, where I did 3 months of radiation oncology. That's part of just understanding what is going on. And your lecture today was like my first week of introduction into radiation oncology. These were the things we were taught. So I work in an integrated cancer center. So we have radiation oncologists there, and there is kind of all the gamma rays and treatment center located there. So we do even wear them passively. Also, we're just in the center. That was one of Ferdinand's question, was really a question I wanted to ask Dr. Tambe, just to know exactly if they are done. I understand, I worked in Cameroon, and I do understand the limits that we have and how to even measure them, because we do send them out for them to be measured and sent back to us. For us medical oncologists in the center, our exposure is really minimal. The only times I go there is I want to go see what they're doing with my patient. I want to go see where they are radiating, or I'm very curious about one thing or the other, or when I'm a fellow and I want to go participate. But in order to better understand. But I just wanted to say that is something we should really think about. I know it's financially very costly, and we have a system in place which is not, it looks like it's not working, and the government needs to really intervene in order to do some subvention. And even Professor Joshua made a statement about ordering tests. I'm going to go more in the clinical aspect, ordering tests that are not necessary. We do that a lot in the US also. We practice a lot of defensive medicine. But research has even shown that defensive medicine, by ordering a lot of tests, you actually put yourself into trouble. People are not sued because of what they did not order. They are sued because of what they ordered and did not look at. So if you swamp yourself with a lot of results and you end up, the radiologist tells you that there is a lump, which is 2 centimeters there, and you need to monitor it every 6 months, and you don't monitor it every 6 months, this guy ends up having lung cancer in the future. He's going to sue you and he's going to win. If he came in with a cough and you did not even order that because you know it's a common cough, you are not going to get sued. So it's just for those who are practicing medicine also in countries that have a lot of litigation. Do not think that when you order a lot of tests that are unnecessary, you're actually protecting yourself. I think you're bringing yourself more litigation than you can ever imagine. So this is just like a side comment. But getting into the machines, I wanted to know, like in the literature, when I was doing my radiation oncology rotations at a point, I read a lot of situations that happened in Brazil. There was a time a hospital was abandoned in Rio de Janeiro. You can Google that out. They left like several nuclear machines out there. Radiation oncology machines were left, was abandoned. These 2 guys got so excited and they saw some good dust powder and they went and picked it up. This ended up almost killing a whole family, multiple family members. So my question, I know is going to be a difficult question for anyone to answer, but what happens to these machines in Cameroon when they die? How do they get disposed of? It's just for us to reflect over it, maybe because Dr. Tambe practices in the hospital and that's not his job, but what happens to all these machines when they die? How are they getting disposed of? We know that radioactive chemicals are actually difficult to even get disposed of, even here, no matter where you are in the world. It's difficult even in every place in the world to know what to do with this equipment. Do we have anything in place in order to take care of this in Cameroon? And that's my first question, but which is just an open question for us to reflect about. My second question is going to the fact that patients who are getting, this is more of patients who are getting different kinds of studies. Do we have any system, or is there any system in place which we can put in place in order to limit patients from getting unnecessary studies? And also in order to motivate doctors to get the right study for patients so that they don't get multiple studies that are unnecessary. I think it's part of it is doing education like you have done now. I think this education, what I have learned today, even being here, what I've learned today, even after having exposure to radiation oncology, it's something I feel every physician, every nurse, every technician needs to know about, because the information you have passed across here is going to help protect us, protect our patients, and even protect our families. So thank you very much.
Thanks, Chairperson. Your remarks have been very, very pertinent, and I really don't have much to say. Say for the question you asked, if there is anything we can do to reduce the number of inappropriate studies in our setting. We are not the first and we are not the only health system to suffer from that, but then the different health centers, health systems suffer from that for different reasons. And a big problem we have is we don't have institutions with regulations. In the US, for example, the American College of Radiology has actually published what they call the appropriateness criteria for medical imaging use. I'll give you a very simple example. The rules are simple. If I have a patient with head injury and I have a Glasgow Coma scale of 13 on 15, for example, what do? I observe my patient in 24 hours. If consciousness levels improve, my patient goes home. If in 24 hours, consciousness level is stationary or deteriorates, I order for brain CT.
Yep.
But once I have a patient with head trauma with a Glasgow coma scale less than or equal to 11, I go in for CT or MRI immediately. Now that helps it keeps a lot of situations where people will ask for these studies, and then it's not going to be helpful in any way. In the UK, they have a guide from the Royal College of Radiologists they call making the best use of the Department of Clinical Radiology, where they have a couple of guidelines on what to ask in what situation. And the European College of Radiology also have what they call iGuide. These are online systems where you can just log in and go into the body region or the clinical indication, and you can see the best possible test that you can request or alternatives. Another thing to do is don't do it alone. Talk with a colleague, talk with a senior colleague. I have a patient with this kind of a situation, and I want to order this test. Is it going to be the best? And often the best person to talk with is a radiologist.
Yep.
I have a situation where a pediatric surgeon sends a nurse with a 1-week-old baby for an invertogram. That's a chest X-ray that is done with the baby downside up or upside down. It's done commonly for an imperforate anus. You see some people still continue to make those kind of requests. But you imagine you have a 7-day-old baby that you have to turn downside up. And once you do that, you have to leave the baby like that for about 5 minutes so that the contents in the bowel are going to descend while the air is going to move up. You can now tell where the blind loop ends and you do your measurements. I said, but nowadays we don't do this kind of studies again. There are alternatives. Not only are you going to use a procedure that's going to sustain a lot of inconvenience, but then you are going to use a certain level, dose of ionizing radiation for a 7-week-old child. But there are alternatives which can even produce better results. An example is a transperineal ultrasound. A transperineal ultrasound is a credible alternative for an invertogram. So, but when you talk with your radiologist, you go to the clinical picture, what do you really want? Now, there's an opportunity to suggest an alternative, or there's an opportunity even to do what you have asked, then we optimize the dose. If what you think is, if you suspect kidney stones, I might not do a urogram. An unenhanced CT scan of the abdomen might suffice to answer the question. So talk with colleagues, make use of guidelines. They are very, very important. Back home, as I said, we don't have institutions that have those procedures. And also our health financing model cannot serve as a defense. If we had a third-party system, then there will be some sort of control over requests, because the insurance will tell you, we are not going to reimburse that. You will not request, say, an MRI of the abdomen because you suspect an acute appendicitis. The first line is going to be an ultrasound scan. If you don't exhaust that possibility, you can't move up higher. So I think education is good. We educate ourselves, we talk with colleagues, we attend meeting CMEs like this, and then we make use of the guidelines that are already existing. I think that is a pathway to solving that particular problem of guidelines, because we have a lot of studies that we request and we don't know that these studies can be harmful. As I said, you have a woman of reproductive age, be very careful. No study should be done without ruling out a potential pregnancy. If you have a woman who is already pregnant and badly needs it, good and fine, you can go ahead and do the test. But inform the patient that the spontaneous risk of an adverse event is 3%. Let them know, and then reassure them that the benefits are going to outweigh whatever risk. I've had a pregnant woman with miliary TB. Of course, the internist, the O&G, nobody thought of it. The symptoms were confused or masked by the constitutional symptoms of pregnancy. So she never got investigated. She had a twin pregnancy and one of the babies died. And is it two weeks postpartum, she herself was dying. And out of curiosity, I decided to do an abdominal ultrasound and a chest radiograph for her. She couldn't even pay for it. And then we had a miliary pattern. We didn't need any biological confirmation, directly put her on treatment, and she's doing very well today. So I think that collaboration is always very, very important. We have come to a point of commoditization of medical imaging. I don't practice like that. Go and do an echography and come. Go and do a brain CT and come. So we treat these modalities as commodities, but it shouldn't be like that. Talking with your colleague on the other side and deciding on what is best for this patient is always the ideal thing to do. Otherwise, busy clinicians request for studies before they examine the patient. You wonder by the time you examine the patient, the echography is already there, the MRI is already there, the CT scan is already there. I'm talking about motivation of doctors. It's a big problem, even in the US. We have two kinds of attitudes at times. When you're in a public facility where you receive a fixed stipend at the end of every month, you are very zealous to implement those radiation protection principles. But once you move to your private facility where you have conflict, financial conflict of interest,
yeah, with RVs,
you want to receive as many people as they can, because that is how you make all the money you need to function in the center. So there is always that problem. I had some studies in the US. Doctors still suffer from that, financial incentives, especially if you do a combination of both public and private practice. So then what do we do? And that is a question. I think the patients can help us. If the patients have good support groups, they can help put pressure on clinicians so that we reduce the amount of studies that we add that might not be necessary. I think if as a physician, a patient asks you one day, doctor, do you really think this study is going to be necessary for me? Those are questions you don't ask a consultant in Cameroon. He gets offended and then might kick you out of his office. But those questions are necessary.
So we get asked those questions every day. Like, yeah, even by cancer patients every day, do you think this MRI is actually going to help me?
Yes.
If not, because I don't want to do it. Just a little follow-up question before I know we're getting to the end of time, but short question. Do the radiology residents, are they obliged, or the attendings, to be able to answer, let's say in teaching hospitals, answer questions from consultants or from other departments, including surgeons and all of that? Because where I train, it's just a model. If you put in any order for any test, which is above a CT scan, the radiology department needs to review it and then agree with you based on your diagnosis and then approve it. Like, that's the standard. If you say, okay, I want an MRI of the pancreas in order to, or an MRI of the pancreas, I'm trying to rule out, or I'm trying to stage a pancreatic cancer, they'll look at that and they'll get back to you. If you say, okay, I want a CT scan of the abdomen and I'm trying to rule out a hepatocellular carcinoma, they'll get back to you to get a triphasic. So does that happen in our?
Thank you very much. The answer is no, it doesn't happen. I mentioned that in my presentation. It is called consultant vetting. Once you do the request has to be vetted by a consultant. We don't have consultant vetting in Cameroon. Typically, a typical case scenario is that the request form gets to the radiology department when the patient has already paid. So we request in the internal medicine unit, the carer goes to the almoner and pays, and then now presents in the radiology department with my form and my receipt. I've been asked to do a CT scan of the abdomen for whatever I've paid. This is my receipt. Can I get my scan? So that is how it typically functions in our public hospitals. We don't have consultant vetting of studies. And that is why it makes work really difficult for us. So I also emphasize on the role of collaboration, because if residents were to, say, for example, you request for an MRI because you want to stage a pancreatic tumor, or you are not sure, maybe it's borderline, CT wasn't clear, and you need an MRI, and your resident takes that form to the imaging department, he meets a resident of radiology, they are going to engage themselves in a discussion that's going to be enriching for both of them. We decide together what is best for our patient. We study together all the previous studies that have been done, and then we now decide what is going to be best for our patient. We don't do that, unfortunately. My time in regional hospital, I did just that. I think most of my doctors will, especially with the GPs, will attest to that. We come with the patient, we sit down if need be, we review the radiograph that was done, we review the echography, we review the patient's clinical picture. Why do I do that? Because we need to decide on what is best for the patient.
Thank you.
Thank you. So we're getting closer to time, and if we can get our questions short a little bit short so that we can close out and go to the parking lot, that would be great. I'm gonna call on Dr. Ghislain. I hope I'm pronouncing that right, but.
Yeah, you do.
Okay, thank you.
Yes, good evening. I'm Dr. Ghislain Fejo. I'm a radiologist working with the Cameroon Baptist Convention in Bingo. Special greeting to my friend Dr. Chin and my senior Dr. Tambi. I think Dr. Tambi has talked a lot. I will not come back on the issue that clinicians don't more consult, they just prescribe exam. When a patient have acute abdomen, they don't consult, they just ask for x-ray and before they see what to do. I just want to come back on the radiation protection issue. Also in Bingo, we have the dosimeter. We have registered to the National Radiation Agency Protection. So what we do is that at the end of the month, we send a dosimeter to Bafusam. They have a center there. They read it and they send back the result with the new dosimeter for the next month. So by the end of September, we are going to send the dosimeter of September and they're going to send another one October. But what is striking is the value. The value don't reflect how people are working in the department. Maybe somebody working in CT scan has much value, high value compared to somebody who was monitoring ultrasound. So that was challenged with the Radiation Protection Agency. The value are not quite, somebody who are not been wearing it, the value look like high. And most of the time, the value look at the same. So we are receiving them, we are confused about the value, whether they check it really well. And we have a, so we receive them every month. They are registered for all our staff. The other problem that I wanted to emphasize that Dr. Tambi maybe has not talked about it. Somebody asked a question about MRI. There's no radiation with MRI, so we can do MRI over other exam. About prescription ship, in our hospital, what we do is that when a patient comes, we want to give the price. And when giving the price exam, we check if it's really reasonable. If not, we discuss with the clinician and we see how to switch. Maybe you are looking for something on the spine by asking abdomen, we ask you, explain to you, and we switch the exam, we change the exam, or we ask you to hold it. So that's why we do a bit in our setting about the prescription. So you have some kind of consultancy. We like the patient to come, we look at the exam, we give the price, and we see whether we need to adjust or not, or ask maybe another exam that is cheaper and that is not really having much realization. That's what I can say for now. Thank you.
Thank you very much, Ghislain, and courage. You are working in a very difficult environment, and I can only say congratulations. I wish you all the best. The problem you highlighted with the dosimeter is not unique to your center. I was in Yaoundé last week, and a very big health facility, category 1 health facility, reported the same problem. where the person working at the secretariat has higher readings than the technicians who actually work in the rooms. So there have been a lot of problems about these discrepant values. To what extent do we accept them? How true are they? Now, there are all kinds of hypotheses. You know, we don't also have the possibility of controlling what the people are doing. You know, I don't know what they use, whether you use an ionization chamber to measure the dose, whatever they use, but we don't have the possibility to verify or to control what they do. They are the only facility. And so they give us the results, and we only realize that, logically speaking, for dosimeters that are only used in the hospital facility, a secretary is going to have higher values than a technologist. And for your second point on the converting the studies, I do that a couple of times, and that is ideal if a doctor comes and meets you and you people discuss over the case, and together you come to a consensus. Because believe me, as you saw from the presentation, a plain abdominal film is a very dangerous exam. A plain abdominal film that we do so commonly is equivalent of 9 months of natural or background radiation. So if I have to put single studies on par, a plain abdominal film is second only to a total body CT in terms of equivalent to natural radiation. So imagine you have a lady of reproductive age, plain abdominal film, or X-ray of the pelvis because she complains of waist pain, without giving a second thought on what might be happening to her ovaries. Now imagine that the ovaries have haploid cells in the oocytes, and then there is a DNA damage that is imperfectly repaired. What do you think is going to happen? You have all the chances of a mutation when this cell is going to divide. So it's just a call for concern. And as I said, 2 words: we have to alert our audience on the effects of ionizing radiation, the biological effects, but then we have to reassure that the effects are rare, but they are there. But the reason for which we are using it is because we want to simply harness the beneficial effects. Thank you very much.
Thank you. We're going to take Dr. Chin, and then we're going to conclude and go to the parking lot. So if you have any questions, you can leave them, you can keep them, not leave them, but keep them for the parking lot, and then we can answer those questions there. And Dr. Tambe, hope you join us in the parking lot so you can answer more questions. We're here for you, and we're ready to give you more.
Yes,
So
good.
Yes.
Good evening to everyone. Good evening to those who are where the time actually is in the evening, and then good day to those who are elsewhere. It's my utmost pleasure to be with you today and to share in this very important event that we have, bi-weekly or weekly as the case may be. I want to start by thanking the moderator of, I don't know how she got to know that my birthday today, but I think it's a special day for me. And we'll start by thanking my director who was there a while ago as well. Was with almost interest that we showed up with this presentation because it touches us in one way or the other. I thank my senior colleague, Professor Tambe. Definitely is a respected colleague of ours, and I know that in whatever case, we have to go back to him when needs be. This issue of ionizing radiation, the challenges we have in Cameroon actually is multifactorial. You see, it's something that spans across the challenges of the state, challenges of the personal, the consultants themselves, and then the patients. What am I trying to say? I will start by outlining what Dr. Gissen and what Prof has just mentioned concerning exams. It is very pathetic that, however, the number of radiologists that we have in the country for now is not sufficient. And the training is definitely not sufficient, as Prof. Riley mentioned, because the time given for all these courses within 7 years is not there. So we have challenges where the sheets that are being sent to us for prescription, they have issues with correlation. It ties with what Prof said. We have those 3 steps to control all of this. The justification, the optimization, and limitation. A lot of justification, I think at school, one of our good profs, Professor Ongolo, did make us notice that clinicians might prescribe the exams, but the radiologist is best place to justify it. That's to confirm the exam if it's needed or not. Like Prof said, you will not come from something that concerns the brain and then the clinician requests an exam of the leg. A typical case is last Friday that I had. I wouldn't imagine that a patient was sent, a child of 12 months old was sent for dysphagia of sudden onset, dysphagia of less than 2 days. And the physician requested that the barium meal be done. Barium meal definitely means that we reduce the child like across and take several slides, several shots of X-ray. And just for me to clock the patient, as Prof. as our Prof used to tell us in school, it is important the radiologist equally performs like a second physician. That's clock the patient if you have time. Just for me to ask 1-2 questions and realize that it couldn't work. Dysphagia for just a few days. And I said, no, I had to reorient the exam without necessarily canceling it completely. But I had to get back to the doctor, the consultant. Unfortunately, the number was not there. I asked for just this X-ray of the neck region to be done. Behold, that child had a coin in the neck, stuck in the neck. A coin stuck in the neck. And if we had just gone ahead to do all what was requested, definitely couldn't even go through because the child couldn't even swallow. By the way, it's not even consistent because that exam has to do with coordination. Swallowing has to do with coordination. So what's my point? There's an issue about confirming the exams from the clinicians. If they don't collaborate to follow guidelines, now the guidelines are not made available for all the consultants, which normally they're supposed to know, but if training doesn't give sufficient time for all these things to be maintained, they need to communicate with radiologists such that the exams are justified. Things must be done when necessary. I remember like 2 years ago, while in Douala, I had physicians who asked for CT scan of the abdomen because of bad odor. Because of bad odor, you will imagine that. And such cases, when you clock the patient, realize that they want to think of funny things as causes for the symptoms. So it is a problem for the physicians to discuss, accept what is needed for a particular case, if it is worthwhile or not. And then, besides this justification, optimization is one important thing that has to be taken into consideration, as Prof. Riley mentioned, because realize that sometimes they will send an exam that will be done, request the physician will just write there with and without contrast medium and whatever. And we realize that to optimize this exam, the protocol you need might not really want to have several shots or scan the patient several times to have the result. You have to cut it down. So in a nutshell, the challenges span between the shortcomings from training, the inability to collaborate with the other colleagues, as Prof. Riley mentioned, all the radiologists, as said, the radiologist is best placed to confirm an exam. But given that I might not have time to discuss with all the consultants, might not have time to clock the patients again. Because sometimes, just like ultrasound, where you are doing ultrasound and you keep talking to the patient, you ask questions, you clock the patient once more. And realize that at the end of the exams, you might have to recommend another complementary exam to answer the problem or to help the physician go forward. So one thing is that when the radiologist clocks the patient, I remember a colleague of mine did a study where she studied the impact of clocking, rearranging the exam by the radiologist and getting the outcome in patient management as a team. And the effect is palpable. When the radiologist participates, it always comes out with much more beneficial effects. I have a problem with the second aspect of certification. One of our panelists did ask, how do we protect the patients? And at the same time, not only the patients, ourselves. Honestly, when it comes to certification, we have these bureaucratic hookups that are blocking us. My director did mention a while ago a situation where we received a regional hospital, and now that was 10 days ago. we did receive dosimeters. But before we received dosimeters, the contract that was sent to us is a problem. It's as if they are there to make money, but not to help. Absolutely not. They are there to make money because in the contract, the clause that were mentioned there, everything was just like setting traps. They were asked, they were mentioned that you are the one to do the transportation for reading. You have to pay for reading. And if you don't do it within 5 days, you pay penalties. If you go between 10 days, you have extra penalties. And people like us, where there is insecurity and ghost towns every now and then, we never respect that. And then if you keep it for 2 days, you consider, or for 1 month, consider you have kept, you have to pay it. So what am I trying to say? The National Radiation Protection Agency is absolutely there, the way it seems, to make money rather than helping the Cameroon, the society move forward with this issue of ionizing radiation. It is just another challenge that we need to face. And I think if there is a concerted effort such that radiologists that are practicing or the Cameroon Society of Radiology can equally write and put pressure through the minister at the same time through this National Radiation Protection Agency to see how to revise their clause. Because the clause don't help absolutely. They don't help. And it's making the situation difficult for everyone. I can see my senior colleague telling me, he's telling us it's been, I mean, he's worked for a while now and he hasn't gotten it. Yeah, he never used it. Of course, the way these guys stand on the way to be a regulatory agency, it definitely, you know, it's not regulating, but it's like they want to make the money. And it made most of the facilities shy away from requesting it. Somebody even asked us, how are we going to do a census, get the number of facilities to see how the facilities can, to have a kind of feedback on how many of them exist, and if there is an optimization optimization at level of regulating radiation. No, because most of these facilities are hiding. Some of them are not even, they don't even declare themselves as existent. Talk less of going to require accreditation. They hide just because these cases and the conditions put forth are not encouraging. So you see, it reflects on what we have in our government. They don't help most of these activities to move forward. So in a nutshell, we say it's a multifactorial problem, and think everyone has to handle it in their own way. What am I doing? What I do at the Regional Hospital Bamenda is, frankly, I've made it a duty. No, especially special X-rays and CT scans, they don't do it unless I validate. If I don't validate them, they will not run them. In fact, not me. I mean, all the registrars are there. That's the policy we have, all three of us. We must validate the exams before they do. It's true somewhere, it might not apply everywhere because of the time constraint, the number of exams to be done, and the workload. But I think everyone at their level could do something and to limit the effect of ionizing radiation to the patients. So I validate it. If it doesn't go, I get back to the consultant, and then we see together if they have to adjust it. If it does not correspond what they want, they will have, like the one yesterday. If I never asked for that X-ray of the neck and I stopped the barrel mill to be done, I would have done it unnecessarily and would have irradiated the child for no good reason. Meanwhile, it wasn't indicated. So these are some of the few things we are doing, and we think, I think it's across the board. Everyone has to chip in one thing or the other in what concerns them. At the same time, as Prof. Riley said, it needs education. Our physicians need to be how can I put it? Need refresher courses from time to time, like this one, so that they will know when to prescribe, when not to prescribe, and have these guidelines. If there's possibility unfortunately, we are few, we don't have enough time. The courses are not coming up as much as they could to help them have this orientation.
Dr. Chin, if I may jump in, it's just amazing listening to your passion as you're articulating these challenges that you're facing. And I'm sure Dr. Tambe would probably feel similarly about some of the challenges you're articulating. And it's exciting for us that we have this platform now, which would serve as a platform to highlight these challenges that are existing in our system and brainstorm and hopefully collaborate in the near future around potential solutions that could make things better going forward. So it's really amazing to hear you articulate these challenges, and we are very passionate about, we're very excited about your passion. And I don't know, Dr. Tambe, do you have any last comments regarding Dr. Chin's remarks?
Thank you very much. I can only encourage Dr. Chin. I think if you have to stay and continue to work within this health system, you need a lot of patience and resilience. Each day I go to work, I tell myself I'm there for the patient. One day myself, I'm going to be one. So I try to do my best. I don't give up. Do what is best for the patient. That is my like my motto every day I go to work. I think what I need to do is to do what is best for the patient. If any standard is not going to be acceptable if I were the patient, believe me, I wouldn't do it for another patient. But do it in a very gentle way and do it with love. No matter how much the system tries to frustrate you, you have to be man enough chin and tell yourself that as long as you stay within the system, leave some positive footprints. If tomorrow Chin is no longer in Bamenda Regional Hospital, what will be said of him? Let at least it be said that as a radiologist, you took care of your patients well. Let colleagues say that each time they had a patient and they were in difficulties, they collaborated with you and you helped them pick out the best study for the patient. You did that and the patient's problem was solved. So I can only thank the organizers, the chairperson of the town hall, and everybody for the wonderful opportunity they gave me. It's really a humbling opportunity, and I just hope I did not disappoint. Thank you very much.
Oh, of course, Doc, you didn't. We've been thrilled. You set people on fire. You can see from Dr. Chin's reaction. You touched on a topic today that has often been neglected and that many people are very passionate about. Unfortunately, out of respect for our audience and the fact that we're already running late on our time, we would have to round up today's session. But we won't leave today's session without giving a shout out to Dr. Elroy Weleji. We see Dr. Weleji is in the house. Dr. Weleji has been a professor to me and many of my peers who are in this call today. He taught us anatomy and surgery at the University of Buea, the first set of batches from the medical school at the University of Buea. And Dr. Weleji is a very passionate surgeon, and we would hope to have him join us sometime here at the town hall. Dr. Weleji, you're muted, and we are sure you're watching us somewhere from Limbe.
Yes, indeed. Thank you very much. Can you hear me?
Yes, Doc, we can hear you.
Can you hear me now?
Yes, we can hear you.
Thank you so much, Alison. I'm proud of you. You were always a very hardworking and ambitious girl, so I'm not surprised. But I must thank Joshua Tambe, my colleague, for all these years, for his great work and his great achievement in producing this work. He has really highlighted the shortcomings we have with our radiology practice. I just wanted to ask him whether there was a regulating body, such as the Cameroon Radiological Society. That's the first question I want to ask him, because it's very important. And of course, because of our cultural problems, there's a lot of problem in the practice of radiology. I would also like to agree with him and with the last participant that the radiologists should take their responsibilities and minimize the failure of the system. I think we should start with that exactly. And he has mentioned that as well. But is there any regulating radiological society in Cameroon, Joshua?
Thank you, Prof. There is a Cameroonian Society of Radiology and Radiation Oncology, but that is just an academic body without a legal status. And so they don't have any regulatory role. They only meet for scientific purposes. So it's not like in other settings where you, at the end of your training, you sit for a board exam with the American College of Radiology, or in West Africa, you have the West African College of Surgeons that has a radiology faculty. So there is an association, but that is it. It's a scientific association. It doesn't have regulatory powers or regulatory authorities. And that is, unlike many other disciplines in Cameroon, many other specialties, the moment you leave school, you are off. There is no CPD. We don't do CPDs in Cameroon. So you practice the way you feel you can, the way you know you can. and nobody ever comes up to, I don't know, to put into question what you do. So we have a problem with regulation. There's no regulatory body in the practice of clinical radiology in Cameroon.
Yeah. Yeah.
And secondly,
I think we should work on the legal aspects.
Yes,
I think
and
we should work
secondly,
on that. Very important.
Yes, the clinical aspect is very important. The radiology is a clinical discipline. And so fortunately, it is most usually considered in Cameroon, they use the word paraclinical. It is not. That's why the UK appropriately use the word Department of Clinical Radiology, because it's not an image that you're interpreting. There's an entire story behind the image. And without the story, you wouldn't be able to make any concrete diagnosis or even give credible differentials. And look at the setting in which we practice. Most physicians, some don't even sign the request form. So you don't know if it is a madman who even made the request. And some patients are coming from out of town, very remote areas. You cannot get to your requesting physician to find out what was the problem. I mean, can I change the test? What's the best thing to do for the patient? So we have all of that. And the way the system is organized, the micro system, as I said, some patients show up for a study with a receipt of payment. So it's like, okay, I have paid for my study that my doctor asked, can you do it for me? You now get into a bitter situation trying to talk the patient out of it that no, this test is not the best. There is something better. You have a 25-year-old lady with a breast lump and an O&G prescribes a mammogram. That is terrible. There are better alternatives. That study can be done, yes, but the truth is going to be completely useless for this lady of 25. But what do we do? So you always have to get into rebuttal with colleagues who think that you want to audit your practice, who think that you doubt their clinical acumen. So all of that comes into play. But we have to continue the collaboration, and we train ourselves. The more you go in for training, and as I said, I've learned a lot from the town hall. I attend the town hall. At times I'm very silent, but I learn a lot from it. So each time you get into places like this, you always pick out something. It's going to help us improve on our practice, Prof.
Okay, thank you very much. I think, thank you, Alison, for giving me the opportunity to say a few words after the great talk by Professor Joshua Tambe. Thank you very much. But I still feel we need a regulating body in Cameroon, definitely. Thank you. Keep the good
so
work
much
going.
for
I hope I will be able to like Professor Joshua Tambe in the future. Thank you.
Yeah, thank you so much, Doc. We have the parking lot that's going to continue right immediately after this. So some of these conversations could continue in the parking lot. Ladies and gentlemen, it's been an amazing 2 hours, 40 minutes, talking radiology with you and listening to Dr. Tambe enlighten us on what we are doing and what we need to be doing better. At this point, we need to officially close the 59th edition of the Town Hall, but I'm going to hand over the floor to our chairman to give us a vote of thanks.
Wow. So I just want to say thank you to everyone who's here today. And truly, everyone keeps saying chairman, but the town hall belongs to all Cameroonians. We started this out of the COVID pandemic, and everyone is an equal shareholder of this town hall. So this is just making sure that we encourage others to come here. If you have someone who is able to enlighten us about a particular topic where we can also create connections, we can get things done in Cameroon, we can move from just talking to action, we can also educate ourselves, get ourselves CME credits, and get practical questions answered. I would take one last word from Professor Tambe Joshua, who I will always repeat, my classmate: garbage in, garbage out. That's the things they tell us. So if you garbage in, once you request a test and you put in garbage, the radiologist is going to give you garbage out. They need a clinical history. And like any other thing, I learned that late in my training. I will not say that. I did residency in Cameroon, moved here, did internal medicine. I hardly spoke to any radiologist during that period, though there were residents calling us to change tests and switch from one test to the other. But during my fellowship in oncology, the most important partner I have ever had is a radiologist and the pathologist, let me say so, but the radiologist in particular. there is no single day I don't call a radiologist more than 3 times to either talk about the best test for the patient, to either talk about what my patient has so they can actually help me interpret the imaging better, or they can actually suggest a better test for this patient. So I think it's a very important topic that we're going to exploit even in the future. So Alison, I just want to thank all the moderators. I don't know how you guys find time to do this and to come in every 2 weeks you guys are here, and we're getting this done. And also I want to encourage those who are here for the first time, please don't leave. We have a parking lot of about 30 minutes. It's not recorded. This is recorded. It's not recorded. It's not on Zoom. On Facebook, we can talk what we want. Some people are having high political positions. They don't want to talk about certain things. There we can really talk about the way forward and also get each other's contact and move forward. So thank you very much, Alison, Brian, and Teresa. And also thank you to Elvis, who started with the session. So it's always a pleasure.
Thank you, Dr. Former. On this note, the 59th edition of the Cameroon Town Hall for Healthcare Professionals is officially closed. We look forward to seeing you again in 2 weeks, where we have exciting discussions lined up for you. In the meantime, all the best to all of you. You take care of yourself and your loved ones. Bye.
Thank you.